Well, dear Dimitri, dear Mark, ladies and gentlemen, first of all, thanks for inviting me to give this talk. For those who don't know me, I'm from Munich, Germany. I'm an office-based outpatient practice cardiologist, but also invasive, doing catheterization, stenting, and so on in a Munich hospital. Actually, my topic is coronary artery disease, Condensed general cardiology. So what I did for this talk, I put together what I thought might be important for office-based general cardiologists to take home from this congress. Here you see the number of presentations and the number of sessions. There was a huge, really, variety of different informations here. And on top, as you are aware, we have 5 new ESC guidelines just came out during this meeting. So I asked myself, were there really game changers? Game changer is when I come home today and doing practice tomorrow, do I change my everyday patient care? Which study actually influenced this? So let's start with the diagnosis of coronary artery disease if it is suspected. So this is not yet known whether the patient has high degree stenosis or not. And I will go a little bit, highlight some parts of the new guidelines called CCS, chronic coronary syndromes, formerly called stable coronary artery disease. So the question is, why did we change the name of stable? Why doesn't stable coronary disease not exist anymore? Well, actually, stable coronary disease was never really stable. And as you can see here, there's an increasing amount of events during the course of stable, so-called stable patients with acute coronary events in between. So these guidelines were created by 25 task members. I personally like the guidelines very much because I had the honor, together with Dimitri, to be one of the reviewers. If you put it together, actually it's a document which was created by 64 people together with 55 pages. So it's a major work you should really read. And I cannot, of course, demonstrate this new guidelines. I just picked up some practical points. And if you compare those with the old guidelines, which are 6 years ago, exercise EKG became even more downgraded, and it is recommended to perform exercise EKG for ischemia detection, not for other things, but for ischemia detection only if imaging methods are not available. But more or less every office-based cardiologist has an imaging method, which is the stress echo, so he should use the stress echo more often. These are the new major recommendations. Of course, there is no time to read this. I show you this just to motivate you to go deep into the paper. It's really worth it. One point I would like to pick up a little bit more details, and this is the prevalence, the pre-test probability of coronary artery disease changing in the last 6 years. The blue lines are the old numbers, and the red dots, the red bars, are the new numbers. And as you can see, there's a dramatic change in the prevalence of coronary artery disease of patients which come to our offices. Just to give you an example, this is the old table, you know this, differentiating the quality of chest pain and the age and the sex, and these are the old numbers. And if you look at the new numbers, at the first glimpse it looks different, very much different. This has really changed. For example, this 30 to 39-year-old male with typical angina had 59% 6 years ago of pretest probability. Now it's only 3%. And in this case, it was 84% and now decreased to 44%. So what does that actually mean to our daily work? It means that the number of patients in between 15 and 85% of probability are increasing. So we need to have more imaging tests. And as you can see above, actually the stress test, the regular exercise EKG here, has a huge gap. So it is not really very helpful. And this is why imaging methods are more and more preferred to help us with this question. Well, this figure may look a little bit confusing at the beginning, but if you look in detail, I think it's a very good and very practical figure. So if a patient has a really low pretest probability, then, and this is also new, the first test actually here is not exercise EKG, is not non-invasive ischemia testing, it's coronary CT angiography, because the strength of CTA is the rule out. If there's intermediate or high likelihood, of course, the traditional ischemic tests, stress echo, myocardial scintigraphy, or if available, magnetic resonance, perfusion imaging is indicated. And the number of patients which should go straight to the cath lab, stable, CCS, not acute coronary syndromes. But if they are really limited and do not respond very well to medical therapy, these are the only group which could go to the cath lab even without those non-invasive tests. So let's get to the CCS, the chronic coronary syndrome. This is the definition of very high-risk patients. I will, for the sake of time, not to go through all these points, but I just want to motivate you to look at it. Why is it so important? Because some things have changed, especially for those who are at very high risk. So for patients in secondary prevention at very high risk, there's a recommendation not only below 70, LDL cholesterol below 70, but now below 55 or below 1.4 millimole per liter, depending which you're using. But also for primary prevention in those patients with very high risk of coronary artery disease, the goal has been lowered to less than 55 for LDL cholesterol. And this is also new and important. If a patient had, in the meantime, a second vascular event within 2 years, then the goal has been again lowered with LDL cholesterol, because now you need more drugs to go below 40 milligram per deciliter. So this is a really tough goal, but the guidelines say you should really try to do this. On top of it, what's important for the general cardiologist practitioner, now we became a little bit diabetologists with prescribing these anti-diabetic drugs for cardiovascular prognosis, and this is independent of the glycemia, independent of the HbA1c. So these two groups of drugs are now cardiology drugs also. And last but not least, what's new is a special device. It's called CS reducer. CS stands for coronary sinus, to ameliorate symptoms in patients who had already many PCIs, had already bypass surgery, and we do not know how to treat the angina. The CS reducer is an option now recommended by the ESC. I think we will hear a lot in the next years by this method. Which brings me to the late-breaking trials, important for the general cardiologist. As you can see here, it was almost impossible to enter the room. It was crowded and people used the overflow areas so everybody could listen. So I picked up only a few studies presented here to, I think, which are important for the general practicing cardiologist. This study was combining or comparing aspirin alone versus aspirin plus ticagrelor in patients with stable CCS and diabetics. As opposed to the Pegasus trial, here patients with primary MI or stroke were excluded. The curves differ a little bit. Yes, it was significant, but not too impressive. And this is why a subgroup analysis showed who these patients are, which benefit from this dual antiplatelet treatment without having a heart attack before, but diabetes. And as you can see, these are the patients with a history of PCI. Why is this? Maybe because patients who had a history of PCI might have been or are sicker than those who didn't. Well, this was the conclusion. Added to aspirin reduces events. But not only this drug, and this is also new in the guidelines, this table of recommendation. So a second antithrombotic drug, in addition to aspirin, is recommended for patients at high risk. I gave you the definition before. Which are the drugs? There are 4 drugs recommended, 3 P2Y12 inhibitors, which you know, but also rivaroxaban is recommended now for prevention in those high-risk patients with a low-dose vascular dose. Another study, I show you just a little slide here because it was very, how much? 3 minutes, okay. Very contemporary registry, only one slide, which I was surprised that angina has not really a prognostic value in patients without prior myocardial infarction, whereas in patients with prior myocardial infarction, angina is a prognostic tool. One study which was presented yesterday, which I think is important to our everyday office-based work, was the Entrust AF. It was a kind of time because we already had 3 similar studies with NOACs and patients getting stents with atrial fibrillation. And no wonder, actually, it's not very surprising that bleeding is less with dual than with triple therapy. But this just published meta-analysis of all 4 NOACs with dual antiplatelet DAPT therapy, omitting aspirin, have less bleeding. Yes, that's not a big surprise, but a little bit astonishing is that there's a signal in each of these studies that stent thrombosis might be slightly, but not significantly elevated. So this raises the question, did we or did the studies remove aspirin too early? So maybe triple therapy is not yet totally out. We will hear a lot of those things in the future. Well, for ACS, acute coronary syndrome, I have only one study because it shows you how exciting some results can be. Ticagrelor versus pradagrel, direct head-to-head comparison, and the hypothesis of this study was that ticagrelor is superior to pradagrel. And as you can see the results, they showed exactly the opposite. So this study, which was not funded by any pharmaceutical company, showed exactly the opposite, what sometimes you are hearing, bleeding the same direction. So to conclude, take-home messages. The term stable CAD has been replaced by CCS. The prevalence of CAD is considerably decreasing. This has a major impact on our non-invasive tests by increasing role of coronary CT. In CAD patients with high risk, the LDL goal is now lower, below 55. For patients with CAD and diabetes, the addition of those anti-diabetic drugs is now recommended independent of HbA1c. For secondary prevention, the new guidelines actually recommend a second anti-thrombotic drug. There are 4 different drugs you can choose according to the guidelines. And the second anti-thrombotic drug could be one of the 3 P2Y12 inhibitors, or what many people prefer, the vascular dose of rivaroxaban. And last but not least, for patients with atrial fibrillation undergoing stenting, I think the case is not closed. We still need more data on the time, what is the optimal time to dismiss aspirin and to go on with dual antithrombotic therapy, because we have to do this in our offices. Thank you.
Thank you very much.